All right, thank you, Dr. Lubert. So like Dr. Lubert said, our presentation is caring for transgender and gender diverse youth. So we have no conflicts of interest or financial disclosures, but there is a personal disclosure that I would like to make before we get started. When Marie and I were deciding to present on this topic, we were initially a bit hesitant. We felt a bit like imposters not being or identifying as transgender ourselves. But ultimately, we decided this is a very important topic and we wanted to do our best to present this information from our own clinical experience and our research on the topic. So the history of instances of transgender go throughout the historical record, are seen in many ancient civilizations, and the history of the transgender rights movement has many important dates. This slide sort of shows an overall timeline and could be a whole presentation on its own, but I just wanted to touch on some of the important dates. So 1952, Christine Jorgensen created awareness of trans issues in America. She was not the first person to have what at the time was called sex reassignment surgery. The first operation was around the 1930s, but she was the first person in America to become well known for this. She made many headlines and became a household name. She had served in World War II and became an advocate for trans issues. So she really brought this issue to the consciousness of America at the time. In 1969, the Stonewall riots occurred. The Stonewall Inn was a sort of a makeshift bar club in New York where the LGBTQ community would gather. And at the time, it was illegal to be dressed in clothing of the opposite sex or to be openly displaying homosexuality. So these kind of bars were often raided. And in 1969, when the bar was raided by the police, which happened frequently, and they started to arrest trans and homosexual patrons, the crowd decided to fight back against the police, and the riots continued for days afterwards. And this really brought to the forefront the fight for LGBTQ rights. Sylvia Rivera and Marsha Johnson were two trans women that were at the riots and really spoke out for trans issues. The two of them went on to found STAR, which is an advocacy group for homeless transgender youth in New York City. It wasn't until 1975 that Minneapolis became the first city to pass an anti-discrimination law protecting transgender people. In 1993, Brandon Teena was one of several transgender people that were murdered in anti-trans hate crimes. And the culmination of this in 1999 was the first Transgender Day of Remembrance for all those that were lost. Also in 1999, the transgender flag was created by Monica Helms. And I think her quote about the flag is worth reading. The stripes at the top and bottom are light blue, the traditional colors of baby boys. The stripes next to them are pink, the traditional color for baby girls. The stripe in the middle is white for those who are intersex, transitioning, or consider themselves having a neutral or undefined gender. The pattern is such that no matter which way you fly it, it is always correct, signifying us finding correctness in our lives. Some more important dates, I won't go through them all specifically, but in 2003, the National Center for Transgender Equality was established. This was followed by a number of firsts in America, our first transgender mayor, presidential appointees, and judge. In 2010, the US State Department eliminated the requirement for surgery to change gender markers on passports. And it wasn't until 2014 that gender identity protection was in place for federal employment. All right, so some terminology. So gender identity is our internal concept of who we are and how we identify on a scale of feminine to masculine, and anywhere in between, or any other gender or neither. So that's kind of in our brain what we identify as. Our gender expression is the external expression of self. So it's the clothes we wear, it's the traits we exhibit, the patterns we have. And an important thing to note is that our identity doesn't always match our expression, especially in children that are still coming to terms and coming out with their true gender identity. Their internal sense of self may be very different from the way they represent themselves externally. So it's important not to make assumptions based on someone's gender expression about their gender identity. So some important developmental milestones to note are that at 2.5 years, children can label male versus female faces, and they have internalized a sense of maleness and femaleness. And a core gender identity is formed by 36 months old. A child has a sense of how they identify. Another important thing to note, when children go through puberty, this becomes a high time of distress for transgender youth. As they develop secondary sex characteristics, this can really highlight some gender dysphoria and some issues that they face. Okay, so pronouns are always important to ask about, and these are some of the traditional pronouns. We're familiar with she, her, hers, he, him, his, and gender neutral being they, them, theirs. These are kind of the most common pronouns. There are others, and it's always important to ask about and not make assumptions regarding this. So some do's and don'ts around pronoun use. Do ask for others' name and pronouns, and use the correct pronouns each time you refer to them. This can be difficult when people, especially with gender nonconforming or gender fluid individuals. And if you make a mistake, just apologize and move on. That's okay. Don't make assumptions about pronouns someone uses. Do try to ask youth pronouns when their parents or caregivers are not in the room. And always ask if you have permission to use their preferred affirmed pronouns in front of others. Don't reveal someone's gender identity and affirmed pronouns in front of others without their permission. This also applies to sexual orientation and relationship status. So this is the gender unicorn. I think some of us might be familiar with the genderbread person. This is sort of the updated version. And this can be really helpful for children and people of all ages in understanding their gender identity, gender expression, and their sexuality. So actually on this website, you can go, and these little black dots are sort of toggle buttons that you can slide along these arrows, and kind of just helps people and children have a sense of where they fall in terms of these different aspects of themselves. So this is some definitions and terminology. I won't go through all of these, and these do relate to sexuality as well as gender. But a couple important ones to note are transgender and transsexual. And just wanted to make the distinction that transsexual is now an outdated term, which used to be used more medically to refer to someone who had gone through surgical procedures to change their gender. So the Trevor Project was founded in 1998 and is a leading organization for crisis intervention and suicide prevention for LGBTQ youth. The mission of the Trevor Project is to end suicide for LGBTQ youth. Since its opening, hundreds of thousands of people have reached out to the Trevor Project in crisis. Some of their services include the Trevor Lifeline, Trevor Chat, Trevor Space, and Trevor Educational Workshops. Another part of the Trevor Project is conducting national surveys on the LGBTQ youth mental health, which is something that we don't have a lot of great data previously. So their national survey looked at about 40,000 LGBTQ youth and unique insights and struggles that they face. So some statistics from the Trevor Project, 61% of transgender and non-binary youth report being prevented or discouraged from using a bathroom that corresponds with their gender identity. 86% of LGBTQ youth said that recent politics have negatively impacted their well-being. Transgender and non-binary youth who report having their pronouns respected by most or all people in their lives attempt suicide at half the rate of those who did not have their pronouns respected. Some other statistics, among LGBTQ youth who considered suicide, over half of the children that identified as transgender had considered suicide at some point. And another interesting point, when separated by age, the younger age group, 13 to 17, had higher rates of considering suicide. And when looking at youth that attempted suicide, we again see that the rate is higher among transgender and non-binary compared to cisgender. 46% of LGBTQ youth respondents reported that they wanted psychological or emotional counseling from a mental health professional, but were unable to receive it in the past 12 months. And I think this is important for us to note as mental health professionals, that these patients are out there and are looking for our services, and there's definitely a shortage of it. Okay, so to discuss the DSM criteria for gender dysphoria, the diagnosis of gender dysphoria was introduced in 2013 in the DSM-5, and it's broken down between children and adolescents and adults. So gender dysphoria in childhood, the official diagnosis includes a marked incongruence between one's experienced/expressed gender and their assigned gender of at least 6 months duration. And in children, this is manifested at least 6 of the following 8 indicators. And at least one of them must include 1A, which is a strong desire to be of the other gender, or an insistence that one is the other gender or some alternative gender. The other criteria here include, for children, preference for clothing of the opposite sex, role-playing and make-believe in the other gender, preference for toys, games, activities that are stereotypical of a particular gender, playmates of the other gender, rejection of the toys and activities that are typical of their assigned gender, and a strong dislike of their anatomy. In adolescents and adults, again, gender dysphoria is defined as incongruence between one's experienced and expressed gender and their natal gender. The difference with adults and adolescents is they require only 2 of the following 6 criteria, and these criteria are more based on the incongruence between their experienced gender and their secondary sex characteristics, but again point to a desire to be of the other gender than they are assigned. And this is another some data from the Trevor study. And just to point out, it's important for us to understand the terminology, but it's also important to ask patients what they mean by it. This slide shows just some of the words that LGBTQ youth to use to describe themselves in terms of their gender and their sexuality, which are much broader than anything we've mentioned so far. And even when youth use something like transgender or gender fluid, I think it's always important to ask what that means to them, because their concept of it may be different than our assumption.
Okay, thank you, Sandra. So I want you all to kind of keep in mind some of the statistics that Sandra had mentioned as they're going to come into play with some of the clinical cases that I'm going to discuss. So the first case I'm going to discuss is CC. CC is a 14-year-old transgender female with a past psychiatric history of major depressive disorder, ADHD, DMDD, PTSD, who was admitted to a tertiary children's hospital for new onset anorexia nervosa and was awaiting inpatient eating disorder facility placement. She had a history of at least 3 acute inpatient psychiatric stays in the past year and had at least 4 suicide attempts. So I got to work with her for at least 3 months while she was awaiting inpatient placement due to insurance issues and limitations with bed availability. She was originally going to go home with the functional family therapy, or the Maudsley method, which is a preferred method for treating anorexia nervosa if that's suitable for the patient, but it was deemed unsuitable for her due to a history of unpredictable and unsupportive family environment. Due to her prolonged stay in the hospital, many staff members tried to be supportive of CC and inclusive of her preferred identity and gave her access to things such as makeup, fake nails, nail polish, and feminine clothing, which helped her express her preferred gender identity. An issue came up, however, when a staff member gave CC a long-haired wig. Some background information is that CC's mother was very against CC's preferred gender identity and transition. And she demanded, when I talked to her about CC and her care, that I would use CC's birth name and use he, him pronouns. One day, CC's mother came to the hospital, saw the feminine items that CC was given, and became very upset. She ripped off CC's wig and started throwing away the belongings that CC had been given. And she eventually had to be escorted out by security, which was a very unfortunate incident for everyone involved. Afterwards, CC was rightfully frustrated and distressed. She expressed thoughts of hopelessness and suicidal ideation. CC, however, was also very insightful and said a few things, such as acknowledging that a lot of her mental health issues had actually stemmed from a lack of family, of being supportive of her gender identity and expression, stating, "My family doesn't understand me. If I have to go back with them, I'll just run away. Being able to express myself is important to me. She just doesn't get it." I thought this case was important to mention because it displayed firsthand the lack of family support affecting a transgender youth detrimentally. It also brought into play legal and ethical issues which are still unresolved at that hospital. There were no policies in place regarding transitioning, providing gender-affirming items to patients, because on one hand, all staff wanted to be encouraging and supportive of the patient's preferred gender and preferences, but on the other hand, CC was still under legal guardianship of her mother, who was upset when she thought the hospital was undermining her, as she kept saying, "CC will just grow out of it. Can't you do something to change his mind?" So research conducted by the Family Acceptance Project found that family accepting behaviors towards LGBTQ youth during adolescence is protective against suicide, depression, substance use, and that that families who were accepting had higher levels of self-esteem, social support, general health compared to those with low levels of family acceptance. LGBTQ youth who had low levels of family acceptance were more than 3 times as likely to have suicidal thoughts, report suicide attempts, versus those who had higher levels of acceptance. This brings me to the last statement by CC's mother, which said, "Can't you do something to change his mind?" So conversion therapy. What is conversion therapy? So conversion therapy refers to any of several dangerous and discredited practices aimed at changing an individual's sexual orientation or gender identity, and people conducting conversion therapy can include licensed professionals, unlicensed ministries, or life coaches. Conversion therapy studies have shown that those who have undergone conversion efforts in therapy are double as likely to attempt suicide than those who have not, And those who have experienced conversion efforts before the age of 10 were 4 times more likely to attempt suicide than the general transgender population. And regarding runaway, which is what Cece had mentioned, LGBTQ youth actually represent as much as 40% of the homeless youth population. So I thought that I would show this this infographic because I thought it was interesting to show how current state law, the actual current state laws on banning conversion therapy. So conversion therapy laws prohibit licensed mental health practitioners from subjecting LGBTQ minors to harmful conversion therapy practices that attempt to change their sexual orientation or gender identity. So in the green, the states with the dark green, they show state law with bans conversion therapy for minors. The light green shows a partial ban for conversion therapy. The orange shows that they are currently in federal judicial circuit with preliminary injunction currently preventing enforcement of conversion therapy bans. And the kind of beige color shows that they have no state law or policy. Pennsylvania, I'm looking at you. So I also wanted to include here that the official policy of ACAP regarding conversion therapy, which simply states that there is no evidence to support application or therapeutic intervention regarding sexual orientation, gender identity, or expression. And ACAP asserts that conversion therapies lack scientific credibility, utility, and that interventions are in fact harmful. So this is the second case that I'm going to discuss. The JS. JS is an 11-year-old gender nonconforming youth who presented to an outpatient mental health clinic in 2019 with a recent history of depression and non-suicidal self-injurious behaviors, cutting. During the initial intake session, this youth stated that depression and the cutting was secondary to distress they felt as being singularly identified as one gender. This youth stated that they had never told anyone besides their sister about their feelings, but felt believed in being able to openly discuss their feelings. So I'm now going to play a clip that this youth recorded regarding thoughts on their gender identity. And then it might be a little bit hard to hear, so I actually scripted what they had mentioned in this recording.
I first knew I did not want to be singularly identified by my assigned sex at birth about 2 years ago in 2019. I felt anxious about telling others how I identified, but also proud and the feeling of it needed to be said. School could do better by becoming more LGBTQ plus welcoming, having unisex bathrooms, more use of gender neutral terms, no uniforms, and LGBTQ plus education. I think doctors and therapists do enough as it is. And I have ongoing struggles with indecisive pronouns. Advice for someone treating LGBTQ young would be to start with making them comfortable first, then going on to the more detailed things and acting about pronouns. How's therapy been going for me?
Yeah.
This is a fine. Helped it with definitely was a lot of advice, good advice for me that I definitely took.
So I've had the pleasure of getting to work with JS for almost 2 years now, and the amount of strength, resilience, and growth that they have shown is amazing. They now feel more comfortable discussing preferred pronouns in school and in other social settings. They discuss openly the importance with their father on educating himself on their preferred gender identity and the correct use of pronouns. They have not engaged in any cutting or non-suicidal self-injurious behavior in the past year. They're doing great in school and their depression is much better. They still have ongoing struggles with guilt regarding pronouns, but are glad to have an open space to discuss any ongoing issues. They also at times waver on discomfort with development of breasts, which we continue to explore, but they have been referred to explore options at a gender affirming primary care clinic, which they have started going to. Okay. So I included these statistics from this Trevor study to just kind of belabor the point. I think Sandra might have mentioned some of them before, but only 1 in 5 transgender and non-binary youth reported their reported they have their pronouns respected by all or most people in their lives, including less than 1 in 10 among those who primarily identified as non-binary. The middle graphic shows most people in their lives do not respect their pronouns, and youth who attempted suicide versus those who had access to binder, shapewear, and gender-affirming clothing was much higher than those who did not. So this brings me to a big part of our presentation, which is discussing gender-affirming care. So gender-affirming care is healthcare that holistically attends to transgender people's physical, mental, and social health needs and well-being while respectfully affirming their gender identity. As psychiatrists, I like to believe we are more well-informed about the importance of accepting one's own preferred identity and pronouns, but it is important in every aspect of a youth's lives to integrate this into all of their care, such as medical treatment, potential hormone, or surgical treatment. So actually for the next couple of slides, it's going to be a lot of writing, but for ACAP system of care, I actually came up with guidelines and recommendations for medical and mental health care professionals who are treating gender nonconforming youth that they can utilize in their everyday practice. So I'll briefly kind of go over them, but I can also share the slides as well if you'd like this information. So number one would be to create a welcoming, safe, and inclusive clinical space, which is gender neutral and promotes diversity. Number two, use of gender inclusive language and phrases and understanding the terminology while avoiding assumptions. Number three, use of appropriate forms, electronic health records, billing systems, patient-centered notification systems, clinical research designed to respect asserted gender while maintaining confidentiality. Ongoing staff and provider education to integrate the core competencies on addressing the emotional and physical needs for this population. Speaking to youth separately from the guardian, especially regarding sensitive topics such as substance use, orientation, identification, sexual reproductive health, while keeping in mind developmental considerations. Also advocating for education, developing liaison relationships with school, other medical providers, and community organizers to promote acceptance, inclusion of all children. Advocating for policies and laws that protect youth who identify as gender nonconforming from discrimination and violence while receiving care. And keeping in mind, gender identity formation is a normal part of development. And finally, referral to other clinicians who provide gender affirming care when necessary for assistance, potentially in transitioning like endocrinology or surgery. So I also wanted to kind of discuss the importance of the effect of the COVID-19 pandemic on transgender and gender nonconforming youth. This is a recent article that I had found. So basically I wanted to touch upon, so I know that some of our colleagues earlier had presented on the great impact of the COVID-19 pandemic recently in Grand Rapids and the detrimental effect on youth mental health. But studies recently have shown that during the pandemic, transgender people who already have higher rates of mental health issues in general have been found to have even worse mental health issues during the COVID-19 pandemic. And this has been found due to several reasons, such as limited access to mental health care providers, which I think is kind of globally for a lot of people who are going through difficulties with mental health during the pandemic. Also, increased barriers to gender affirming medical care, postponement of potential surgeries or receiving hormones, which if they're doing a potential optimal timeline, such as puberty, this may cause them to miss an optimal window. Court closures and legal rights, like if they're in the process of changing their name. So these are all kind of things that have affected the transgender population during the pandemic, which is something to keep in mind. Another thing that I thought was interesting to kind of note, and this is from a really recent article on CNN, and it states this record-breaking year for anti-transgender legislation would affect minors the most. So briefly, like talking about this article, they said that there's 33 states have introduced more than 117 bills that aim to curb the rights of transgender people in 2021, which is record-breaking year for such legislation. In 2020, there were only 79. Arkansas is the first state to outright outlaw providing gender affirming treatment to minors. This is the largest number since the Human Rights Campaign started tracking anti-LGBTQ legislation more than 15 years ago. So this is all happening now. What a lot of these bills are targeting are three things. So number one is the ban on participation in same-gender youth sports. Like 31 states have tried to ban athletes from participating in sports consistent with gender identities. Lawmakers are introducing bills supported by conservative legal groups such as the Alliance Defending Freedom. Another thing that these bills are targeting is a ban on gender-affirming care for minors. So 20 states have introduced bills that prohibit or impede administration of gender-affirming therapy to minors. There's a bill in Alabama which might make it a felony for medical providers to provide transition related to transgender minors. And in Arkansas, there is the Save Adolescents from Experimentation Act, which prohibits healthcare professionals from administering gender-affirming care. So, and another thing that the bill is targeting is curriculum bans, ID restrictions, and other legislation. So they're targeting education, and actually asking for needing consent from teachers and parents to actually discuss gender identity in the classroom. So these are all things going on right now. So there are beliefs that these bills are politically driven to be in direct opposition to Biden's administration position on transgender rights. On March 31st, President Joe Biden issued the first ever federal proclamation of its kind for this year's International Transgender Day of Visibility. This annual event, which should occur on March 31st, is dedicated to celebrating transgender people and raising awareness of discrimination faced by transgender people worldwide, as well as a celebration of their contributions to society. On the same day, the Pentagon issued new policies to allow transgender Americans to serve openly in the military, reversing the Trump administration's ban. Biden campaigned on prioritizing issues facing LGBTQ youth and has issued several executive actions intended to advance LGBTQ rights. Whatever the case may be for the rise in anti-transgender laws this past year, in which this has been a year where we have all been isolated from one another and where our children and youth particularly have had a difficult time, isolating those who identify as part of the LGBTQ population is likely to have detrimental effects. So what can we do during the pandemic to care for LGBTQ kids? So I found this nice kind of information from ACAP again. So they have it with a little mnemonic, LGBTQ. So first one is L, list your pronouns in your telehealth platform, which is kind of what we request for you all to do for this presentation. It's a way to not only show your support, but also to just normalize it. We were told that sometimes with transgender, gender nonconforming people, when they are actually using their pronouns and identifiers in Zoom, they almost feel targeted because they're typically the only one in the room who has that. So that's just a simple way to, be more inclusive. Also, guaranteeing privacy in your clinical encounters, even when done by telehealth, which should be the case with, I'm guessing, most clinical encounters that you're doing. Bolstering family support for a child's identity. We have already discussed how important family support is for this vulnerable population. So I think that's just something else that just needs to be said. Teaching practical tools that can help youth cope with stress. Which as psychiatrists, I think that it's always useful to have in our toolbox ways that youth can deal with stress. And question who is in youth support network and brainstorm how to expand support during physical distancing in a safe and sustainable way. So the last name may seem familiar to you on this slide. Maddie Lubert is in their 5th year teaching at Kensington High School. They teach 9th grade English and oversee the Gay Straight Alliance at their school and are one of the organizers of the Caucus of Working Educators. They use they, them pronouns and are in close relation to an integral part of the Child and Adolescent Fellowship here at Jefferson. Maddie originally wanted to be here in real time during grand rounds, but had school obligations. However, they graciously decided to assist our presentation by making the short video of recommendations to take home while interacting with queer and gender diverse youth.
Hi, My name is Maddie Lubert. I am an English teacher at Kensington Health Sciences Academy, which is a neighborhood high school in Kensington. And I'm just here to talk a little bit about how you can support queer or trans or gender nonconforming youth that you work with. So I mentioned that I'm a high school teacher. I am also an organizer with the Caucus of Working Educators, and I've done a lot of advocacy work within the School District of Philadelphia to try and draw attention to issues involving trans and gender nonconforming kids and trying to make sure their rights are respected and that their identities are affirmed. So I just wanted to share some advice that might feel basic, but really is very powerful and can go a very far way in this work. So the first thing is just to always trust the young person. They are the expert on their lives and experience. They know who they are, and they know what they're feeling, right? I think a lot of times it's easy to want to talk to a queer trans kid as if they're maybe confused or going through something, or trying to figure out what precipitous event might have led to whatever conversation is happening, right? But really, we know trans kids aren't wrong. We know they're not broken. We know that their identities are special and important, and they know them. So we should definitely make sure that we follow their lead, and we should trust them when they tell us about their experience. And at times that can be tough because you want to respect and trust the parent, you want to respect and trust other professionals. But again, the child is why we're there, right? The child is the person that we want to care for, and their experience is what matters here. The other thing that can be really important is just not waiting for the proof that you need to be affirming and welcoming to trans and gender nonconforming youth. All of you have probably dealt with a patient that is trans or gender nonconforming or queer in some way, whether or not you're aware of that fact and whether or not that person even openly identified that way at the time, right? We just, specifically by numbers, you've had a kid in front of you. So whether or not you realize it, children, young people are looking for clues to know whether or not it's safe to talk to the adult in the room or to talk openly to the adult in the room. So, really simple things like sharing your pronouns whenever you introduce yourself to anybody, not just when you look at someone and you're like, oh, you might be trans. Sharing your pronouns in your email signature, putting them on your little Zoom tagline so that folks know how to address you. Having, just like normal, natural conversations that include topics related to LGBTQ identities or even famous people or people in appropriate ways, of course, but making sure those conversations can happen naturally and not shying away from them because you're afraid you're stepping over a line. So again, we've all dealt with queer and trans kids, whether or not we've known it. And, we might have done a good job, we might not have, but we can definitely do more. We can definitely support our children more. And we can be proactive about that. And with those proactive things like sharing pronouns or including a safe space placard in your office or, other kinds of images that might be affirming of LGBTQ identities or heroes, those things are really important. But it's even more important that you follow that up with practice and with education, right? None of you know everything. I don't know everything about this topic. And things will also constantly change, especially once, the language changes and becomes different people start identifying in different ways. This stuff is always in flux. So it requires not only you to do the thing like, here's my pronouns, I'm really proud of myself for including it, or here's my safe space sign in my office, I'm really proud of myself. You have to then back it up with the actions and affirming space that you can provide for the young people, and you have to also continue to educate yourself. You're all very highly educated people. Unfortunately, you have no excuse when it comes to barriers to educating yourself, except for maybe time. But I would argue that if it were important enough to you as a practitioner, you would make time. And even simple things like reading young adult literature with trans and gender nonconforming characters, or even just watching media with trans and gender nonconforming characters. Again, that's not everything, but that is a way that you can continue to teach yourself and familiarize yourself with these identities. That may match patients that you work with. So that's just a little bit of advice. It's not much, but it can be really important. And thank you for giving me the time to speak. I am Dr. Lubert's youngest kid, but I am also someone who works really hard to advocate and support the LGBTQ community in schools. One last thing, if you have a student that's a public school student or a charter school student in Philadelphia, they do have enumerated rights related to their trans or gender nonconforming identity, such as changing their name on records, using the proper bathroom, etc., in policy 252. So it is important that if you have public school students in front of you, you know that they have rights in policy 252. All right. Well, thank you so much for your time, and I hope you guys have learned a lot.
All right, so now we just kind of wanted to get into some resources that are available. So the first resource I'm going to talk about is the Mazzoni Center. The Mazzoni Center provides quality, comprehensive health and wellness services in an LGBTQ focused environment while preserving the dignity and improving the quality of life of the individuals they serve. They offer gender affirming care. They're a health center. They do testing and prevention of STIs and HIV. They offer groups and other supportive services. They have 2 locations in Philadelphia, one on Bainbridge Street and one in Locust Street. So here's just some of the names, the addresses and phone numbers. Another resource that we think is really helpful is the Attic Youth Center. So the Attic creates opportunities for lesbian, gay, bisexual, transgender, queer, and questioning youth to develop into healthy, independent, civic-minded adults within a safe and supportive community, and it promotes the acceptance of LGBTQ youth in society. They're the only organization in Philadelphia who is exclusively serving the LGBTQ youth population. Their goal is to reduce isolation felt by LGBTQ youth by providing a sense of community and developing programs and services to counteract the prejudice and oppression that LGBTQ youth often face. All the Attic programming is based on a youth development model and aims to build community, reduce isolation, combat homophobia, promote knowledge and life skills, and develop future leaders. Another resource is the Covenant House Homeless Youth Shelter, which is available for youth under age 21. So again, we had mentioned earlier that LGBTQ youth actually comprise 1/4 of the homeless youth population. So for more than 4 decades, Covenant House has helped transform and save the lives of more than 1 million homeless, runaway, and trafficked young people. They offer housing and support services to young people in need, currently reaching 74,000 youth a year. So I think that this is a really good resource too. I mean, even relating back to my KCC, when they were just, you know, she was considering running away, I think this is a really helpful resource. And then the last one was the Trevor Project, but I know that Sandra had already talked about that, and we used a lot of their statistics for our presentation. So wrap up and you know, brief summary. Some things we wanted you to take away from this are: core gender identity is established by 3 years old. Pronouns are important. Always ask, don't assume. Transgender and gender nonconforming youth are at higher risk of reporting psychological distress, self-harm, suicidal ideation, bullying, feeling unsafe in school, and difficulties in obtaining medical and mental health care. Proper evaluation and treatment of this population can help determine the impact of medical intervention, education, and mental health support of these youths. All disciplinary settings for which a youth in this population participates in, medical, mental, etc., would benefit from continued education and inclusion to treat this patient population, schools, etc. More research is needed to improve understanding of gender identity, gender dysphoria, and transgender experience, particularly among youth population, as most research is actually done on adults. Not every youth who is gender nonconforming has gender dysphoria, but it is important to screen for. And examining the social environments of transgender youth is critical for the development of appropriate interventions necessary to improve the lives of transgender people. So thank you so much for your participation, for listening, and we're open to any questions. Here is our contact information if you have any additional questions or concerns.
So I just wanted to thank you both, Marie and Sandra, for this very good sort of overview of the needs of youth with TQ needs and presentations. I think it's good for us to kind of review this for ourselves and be available and kind of be open to that learning process that you all are kind of presenting to us. So thank you very much. Is there any questions? Please let us know.
I just wanted to say thank you and thank you for sending the slides because this was super great and the video was really helpful. And I just wanted to mention also that there's like a 10% overlap between the LGBTQ community and autism, and also autism and LGBTQ. It's just so, anyway, thank you.
So Dr. Ross, yeah, that was actually something we wanted to mention in our slides, but then it was getting too long. We're like, oh my gosh, we don't know what to fit in and not, but yeah, so that was, but you're definitely right.
Marie and Sandra, I thought it was a really nice presentation. I really enjoyed hearing directly from your patient and from Maddie. So you talked a lot about family acceptance, and as child psychiatrists, we work within a family context. So I'm wondering if you have thoughts on how to approach families that are really struggling with coming to terms with their child's identity.
So I'll give an example for, say, my actual patient, JS. So their father is actually still kind of struggling coming to terms with, their preferred pronouns and things like that. But I think, it's important to, first take the youth lead. So I discuss with my patient, how comfortable they are with discussing this with family. And then when I even asked if they wanted it to be part of the session with her, with the dad and the patient. But then the patient actually just discussed with their dad. And then I encouraged ongoing conversations with the dad if they had any questions. And then kind of leaving it up to them, offering to be supportive if there's any way that we can be supportive, offering for parents to educate themselves, providing clinical resources on how they can educate themselves, being available for any questions, just knowing that you're there and to be used as a resource and a support system. And and I think it's also important to emphasize like the implications that we're obviously kind of seeing on how non-acceptance can detrimentally affect, youth who aren't being accepted.
Thank you.
Hi, I have a question as well, if no one else has one. I also wanted to thank you both for the great presentation. It was really informative. I wanted to go back to what Sandra had mentioned about the beginning about the disclosures, kind of mentioning this imposter sort of this idea of being sort of a little bit of an outsider. And I think sometimes it can be difficult to know what the right questions are to ask. And you mentioned at the end that, patients may or may not have dysphoria, even if they're, gender nonconforming. And so I guess I wanted to see if you'd come across anything like that, or how you would suggest bringing that up, especially in a patient who may be less likely to be sort of forthcoming about the stress they're under, is, not wanting to seem like another person in their life who doesn't quite get it, but wants to be supportive, but, wanting to kind of, but also not wanting to avoid the whole issue. So I appreciate that you mentioned that. Thanks.
Yeah. And so I think your question was like how to approach that with patients talking about gender and.
Yeah, like if you're their provider and expressing, like you're saying, sort of an environment that's welcoming, but then maybe I guess in one of my cases, my impression is that the patient feels more comfortable with others who are also more in the community that they identify with. And so how can I understand or sort of be feel like I'm part of their circle in a way.
Mhm. Yeah, so
Can I
I
give a-
think
sorry, I'm sorry.
Maddie, oh,
Can
that's
I
okay.
interrupt with a little plug that, so at my own side of the clinic, at the Center City Clinic for Behavioral Medicine, as a lot of y'all know, we work with a lot of trans, non-binary, and gender expansive folks. And this incoming year, in July, we have 3 non-binary clinicians joining our crew, which I'm super psyched about, because a lot of trans patients, particularly non-binary patients, will request a provider who is kind of in the circle. Because it's true, like for me as a cis woman, I can't pretend to be in the circle. And my best bet is like kind of like what Maggie was saying, like reading a lot of materials written by trans people, whether it's like young adult fiction or, you know, like actual like textbooks. Sorry to hijack.
No, that's okay. Thank you for adding. I was gonna, say the same thing. I think Maddie gave some good tips on that of sort of educating yourself and presenting, you know, having some signs, whether it's your pronouns in your Zoom title or, you know, an LGBTQ flag in your office or a sign, and then just being open to hearing their experience. I think with anything we're unfamiliar with, I think being honest is always the best approach, and, you know, asking patients what their experience is. And I think especially with kids, when this is still new to them and they may have not come out yet, giving them multiple opportunities to kind of explore and discuss their gender identity.
I think in the middle of that, it's probably good. You know, there's always timing, and supervision will always help, you know, for our fellows when they're approaching these things. But to make it, you know, acceptable for your patient to be able to talk about whether or not they feel comfortable working with you versus somebody else. You know, I think we can be very helpful to people, but sometimes it's important for them to be able to say that, and we have to be open to it and allow them the ability to have that discussion with us.
I have just a comment, how to deal with parents. Since I deal with many of those families here, in fact, the inpatient adolescents. And it's interesting, some parents would tell me that I lost my child, as if there's a death, a loss of my daughter, or loss of my son. And they go through the feelings of grief, even the stages of grief somehow. So it's good to understand also the parent, what stage they are in. The good thing about that is it is not total loss. Actually, what they don't realize, there is gain. The daughter, there is a gain on the other side, but they have to allow themselves to accept, which takes time, because you have really to be very patient with those parents to understand where they're coming from. Not just to confront or push things on them when they are not fully ready, because they do go through this bereavement, unfortunately. The imagined boy or the imagined girl that they've been living and thinking in all their lives. That's a major loss for a parent. But as I said, they have to allow themselves, with the help of therapy, to gain. They will gain the same child, different gender, but it will have probably much better relationship. And they will build together new memories and new desires for the new child. So I think understanding that point for parents, I think is important in approaching parents.
I just want to say how much I appreciate this presentation, a little bit of history. I did a fellowship with John Fryer, who was the masked man at the APA prior to when they removed homosexuality as a diagnosis. And all the time I knew him and I was friendly with him, he kept it as a secret. It was just so in the closet at that point. We have come an enormous long way, and thank you for this presentation.
Thank you. I think if we don't have any other questions, I know we're coming up on 12 o'clock. So I think we can conclude.
Very good. Thank you, guys. Thank everybody for their participation.